Good afternoon and welcome. I am excited to be at the 9th ARESA Annual Research Ethics Seminar, and in line with this theme, I am presenting a study we conducted in Zambia, the health systems responses and ethical challenges to the health needs of the refugees, the case of COVID-19 pandemic in Zambia. I am Victor Chalwe, the Deputy Director at the National Health Research Authority. These are strange and unprecedented times in the wake of COVID-19 pandemic, and most of our frontline health workers are facing something that they have not experienced before, and this is due to the numerous events that they are going through, which has impacted their psychological well-being and definitely affected their performance. This is exacerbated by serious shifts in protocols that they have to go through to adjust and attend to new cases of COVID, shortages of resources that are an ongoing issue, and of course with COVID there is increased number of patients that they have to face on a daily basis. Other constraints include lack of PPEs, transport and housing, and this is further compounded by now increased number of deaths, patients that are in isolation, and also the issue of just dying alone. And of course, for others, there is an ever-present fear of being infected and infecting colleagues or family or friends due to lack of these protective gears at workplace. And so this has definitely inflicted moral injury, which they have to stress to make decisions and give priorities to which patients, when and how, in a constrained environment. When we reflect on the refugee camps and the refugee situation, in the midst of this, we have Zambia is harboring quite a number of refugees from neighboring countries, and in there we have high population density, poor health status, and also limited health services. Just to depict what I've highlighted, we have over 90,000 refugees in about 4 different major refugee camps that we have. In the northern part, mostly Congolese. In the northwestern part of the country, again, mostly Congolese and some from Angola. And in western part of the country, we have refugees in Mayokwa coming from Angola. And then we have in the eastern side of the country, refugees coming from Mozambique. The research question we had was that how has the Zambian health care system responded to the COVID-19 pandemic to provide health services in an equitable manner to vulnerable population like refugees. The study deployed a qualitative study approach, and this involved structured interviews with 31 key informants and 60 participants that took part in focus group discussions. The interview protocol was designed to elicit descriptive information regarding opinions, attitudes, and examine the health system's response and challenges in addressing the COVID-19 disease among refugees in Zambia. Participants were recruited for the study using a purposive sampling approach. Interviews were conducted in person and lasted approximately 25 to 35 minutes for in-depth interviews and approximately 60 minutes focus group discussions. Data were analyzed using a qualitative descriptive approach. Overall, in terms of results, study participants had a good understanding of COVID-19 preventive measures, and additionally, staff from the camps received formal training in use of PPEs for airborne transmitted infections such as COVID. However, it was our finding that the issues of masking, social distance, and self-isolation and regular hand washing were looked upon as being a luxury based on the limited space in refugee settlements. Other major findings included challenges of inadequate health staff, inadequate protective gear, lack of transportation, inadequate infrastructure, non-adherence to COVID-19 safety measures, and these were further compounded by unstable power sources and inadequacy in drug supply. Some of the strategies that our healthcare workers working in these settings have been coping with included training of community members in COVID-19 prevention, use of existing structures and facilities to make room for quarantine and treatment centers, and of course, utilization of locally made masks. In conclusion, the pandemic has basically highlighted how long-standing health, housing, financial inequities interact with COVID-19 virus, exerting a disproportionate impact on those already faced with disadvantage and discrimination. And consequently, ethical decision-making must pay more attention to the interaction between COVID-19 and long-standing health and socioeconomic inequalities. In terms of recommendations, broadly, we suggest adopting a comprehensive health advocacy strategy grounded in the right to health care for all. Further, adopting a multi-sectoral approach, tackling the social determinants of health so that some of the other elements around masking, around social distancing could be addressed in such an environment. Seeking diversified funding at national level. This is critical because we see that based on the resources from the Ministry of Health, it is limited and more needs to be done. Further, improving coordination and collaboration between various actors involved in migrant health. At granular level, in terms of recommendations, institutions such as Ministry of Health and others must provide the resources needed to improve the well-being of our healthcare staff, and this should be done during the current pandemic, but even beyond it. Inadequacy in staffing and the levels of stocking should also be addressed. In terms of equity, we see that it might not be what may be done in one place could be applied directly in another place. And so in such an environment as refugee camps, social distance and masking could be difficult, but hand washing may be easier to implement, and so that could be a huge area to start with some interventions. Thank you so much for listening, and I can welcome some questions and clarifications or any comments. Thank you.